Welcome to the PAD podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter, and Instagram with the handle bar at Shafir Ahmad 4109. And please feel free to share these chunks of knowledge. Thank you. Today, the topic of discussion of our podcast is breast cancers. So, before jumping into the details of breast cancers, first of all, I would like to discuss the histology of a normal breast. So, each breast has been divided into 15 to 20 lobes. So, 15 to 20 lobes are present in each side of the breast. Then, inside the lobes, you will find numerous lobules that has been covered by alveoli or acini. So emerging out from those lobules, there is lactiferous duct, which while reaching towards the nipple area will dilate at the very peripheral side and will convert into lactiferous sinus. So lactiferous sinus is the dilation of lactiferous duct while reaching towards the nipple. In between the lobes of the breast, you will find connective tissue capsule. So briefly overview about the ductal system in the female breast is that the tubulo-alveolar unit consists of simple columnar epithelium. So the point to note here is that the breast tissue changes during pregnancy, menstruation, and in the normal phase. There is slight difference in the epithelium structure, but generally speaking, the tubulo-alveolar unit consists of simple columnar epithelium. Intralobular duct consists of simple cuboidal epithelium. Interlobar duct consists of stratified columnar epithelium. And the lactiferous duct consists of cuboidal or pseudostratified columnar epithelium, and the terminal part of the lactiferous duct consists of stratified squamous keratinized epithelium. So if we can see that the terminal duct lobular unit is the functional unit of the breasts. Lobules make milk that drain through ducts to the nipple. So lobules and ducts are lined by two layers of epithelium. One is the luminal cell layer, which is the inner cell layer lining the ducts and lobules responsible for milk production in the lobules. And the second layer is myoepithelial cell layer, that's the outer cell layer lining ducts and lobules, and it's the contractile unit of the breast, and the function of it is to propel milk towards the nipple. Tumors are the most important lesion of the female breast. Although they may arise from connective tissue or epithelial structures, it is the epithelial structure that give rise to the common breast neoplasms. So the first one we are discussing is known as fibroadenoma. Adenomas are basically benign epithelial tumors, and fibro means fibrous tissue. So fibroadenoma is by far the most common benign neoplasm of the female breast. It is biphasic, meaning that it is composed of both fibroblastic stroma and epithelium-lined glands. However, only the stromal cells are truly neoplastic and are clonal. So fibroadenomas typically appear in young women with a peak incidence at the third decade of the life. They usually manifest as solitary, discrete, mobile masses. An absolute or relative increase in estrogen is thought to contribute to their development. In addition, fibroadenomas may enlarge late in the menstrual cycle and during pregnancy. However, after menopause, they may regress and calcify. So, fibroadenomas, if you can see a radiograph image of the fibroadenoma, you will see a well circumscribed mass will be seen on radiograph. In gross specimen, you will see that fibroadenoma consists of rubbery, well circumscribed mass that is clearly demarcated from the surrounding adipose tissues. On histopathology image, the proliferation of intralobular stroma can be seen to compress the entrapped gland, thus creating a pushing border that is sharply delineated from the surrounding normal tissue. And if we can see the morphology of the fibroadenomas form discrete masses with the sizes 1 cm to 10 cm in diameter and of firm consistency. A cut section shows a uniform tan white color punctuated by softer yellow pink specks representing the glandular areas. Histological examination shows a loose fibroblastic stroma containing duct-like epithelium-lined spaces of various shapes and sizes. As in normal breast tissue, these glandular spaces are lined by luminal and myoepithelial cells with a well-defined intact basement membrane. So the point to note is that in fibroadenoma, the basement membrane is intact. Then we have phylloids tumor. So like fibroadenoma, phylloids tumors are also biphasic, being composed of neoplastic stromal cells and epithelium-lined glands. However, the stromal element of these tumors is more cellular and abundant, often forming epithelium-lined leaf-like projections. So phylloids is basically a Greek word and it means leaf-like. So these tumors are much less common than fibroadenomas and arise de novo, not from pre-existing fibroadenomas. So in the past, they had given the name cystosarcoma phylloides, an unfortunate term because these tumors are usually benign. So ominous changes suggesting malignancy will include increased stromal cellularity, anaplasia, high mitotic activity, rapid increase in size, and infiltrative margins. So fortunately, most phylloids tumor remain localized and are cured by excision. Malignant lesions may recur, but they also tend to remain localized. Only 15% of all cases are fully malignant, metastasizing to distant sites. Now the third benign tumor is intraductal papilloma. So intraductal papilloma is a benign neoplastic papillary growth. It is most often seen in premenopausal women, and these lesions typically are solitary and found within the principal lactiferous ducts or sinuses, as discussed in the histology of the female breast. Right at the start of the podcast, we have discussed that what lactiferous ducts and sinuses are. So the clinical presentations may include serous or bloody nipple discharge, the presence of small subareolar tumor a few millimeter in diameter, and nipple retraction in rare instances. So the tumor usually are solitary and less than 1 centimeter in diameter, consisting of delicate branching growths within a dilated duct. Now on histologic examination, they are composed of multiple papillae, which are the finger growth-like projections, and each having a connective tissue coat covered by epithelial cells that are double layered with an outer luminal layer overlying a myoepithelial layer. The presence of double layered epithelium helps to distinguish intraductal papilloma from intraductal papillary carcinoma, which can present with clinical features similar to benign papilloma. So intraductal papillary carcinoma and intraductal papilloma may have the same clinical features, but intraductal papilloma on histopathological examination, you will find myoepithelial layer. However, in intraductal papillary carcinoma, myoepithelial layer will not be present, and it is a distinguishing point between these two tumors. Now we will start discussing the carcinomas, which are known as the full-blown malignant tumors of the breasts. So in 2010, more than 200,000 invasive breast cancers were diagnosed in women in the United States, and around 40,000 women died of this disease, making this second only to lung cancer as a cause of cancer-related death in women. The lifetime risk of developing breast cancer is 1 in 8 for women in the United States. During the past 3 decades, the mortality rate among those diagnosed with breast cancer has dropped from 30% to 20%, mostly as a result of improved screening and treatment. So, if we can see the epidemiology and risk factors, so a large number of risk factors for breast cancers have been identified. Some are well established and some are less well established groups, and indicate that when possible the relative risks posed by each. So, some of the important risk factors are summarized in our podcasts. So, the first one is the age. So, risk steadily increases throughout life, especially after menopause, peaking at roughly 80 years of age. 75% of women with breast cancer are older than 50 years of age, and only 5% are younger than 40. Then the geographic variations is also risk factor, and surprising differences in the incidence and mortality rates of breast cancer have been reported for various countries. The risk for development of this disease is significantly higher in North America and Northern Europe than in Asia and Africa. For example, the incidence and mortality rates are 5 times higher in the United States than in Japan. And these differences seem to be environmental rather than genetic in origin, because migrants from low incidence to high incidence areas tend to acquire the rates of their adoptive countries and vice versa. So it seems that diet, reproductive patterns, and nursing habits are thought to be involved in the pathogenesis of this deadly disease. If you can see the race and ethnicity, so the highest rate of breast cancer is in non-Hispanic white women. However, Hispanic and African American women tend to develop cancer at a younger age and are more likely to develop aggressive tumors that present at an advanced stage. So, such disparities between ethnicities are an area of intense study and currently are thought to be due to combination of genetic differences and social factors such as lifestyle choices and access to health care. So, some of the other risk factors which are important are worth mentioning. For example, prolonged exposure to exogenous estrogens postmenopausally, as occurs with hormone replacement therapy, has been proved to be useful for prevention of osteoporosis. However, according to the recent studies, relatively short term use of combined estrogen plus progestin hormone therapy is associated with an increased risk of breast cancer, diagnosis at a more advanced stage of breast cancer, and higher incidence of abnormal mammograms. Because the 2002 Women's Health Initiative report suggested greater harm than benefit of combined estrogen plus a progestin, so a precipitous decline has occurred in estrogen and progestin use, along with serious re-evaluation of perimenopausal hormonal therapy. On the other hand, oral contraceptives have not been shown to affect the risk of breast cancer. even in women who have taken the pill for a long time or in women with a family history of breast cancer. Ionizing radiation to the chest increases the risk of breast cancer. The magnitude of the risk depends on the radiation dose, the time since exposure, and age. Only women in whom radiation occurred before age 30 during breast development seem to be affected. For example, breast cancer develops in 20% to 30% of women who underwent irradiation for Hodgkin lymphoma in their teens and 20s. But the risk for women treated later in life is not elevated. So, of importance that the low doses of radiation associated with mammographic screening have no significant effect on the incidence of breast cancer, and this is an important point to note. So, many other well established risk factors such as obesity, alcohol consumption, and a diet high in fats have been implicated in the development of breast cancer by analysis of population studies. The risk associated with obesity probably is due to exposure of breast to estrogen produced by adipose tissue. So now we will discuss pathogenesis of breast cancer, that how breast cancer emerges out. So the causes of breast cancer remain incompletely understood. However, three sets of influence seem to be important. Number one is the genetic changes, the second is hormonal influence, and the third is environmental variables. So, first, we are going to discuss the genetic changes. So, as with all cancers, mutations affecting proto-oncogenes and tumor suppressor genes in breast epithelium underlie oncogenesis. And among the best characterized is overexpression of HER2-neu proto-oncogene. So, HER2-neu proto-oncogene undergoes amplification in up to 30% of invasive breast cancers. Now, this gene is a member of epidermal growth factor receptor family, and its overexpression is associated with a poor prognosis. Amplification of RAS and MYC genes also has been reported in some human breast cancers. Mutations of the well-known tumor suppressor genes retinoblastoma RB and famous P53 also may be present. A large number of genes, including the estrogen receptor gene, may be inactivated by promoter hypermethylation. Undoubtedly, the transformation process involves multiple acquired genetic alterations which can occur in various combinations, thereby giving rise to different subtypes of breast cancer. Gene expression profiling can separate breast cancer into four molecular subtypes. One is luminal A, in which there is estrogen receptor positive, HER2-neu negative. The second is luminal B, estrogen receptor positive, HER2-neu overexpressing. The third one is HER2-neu positive, HER2-neu overexpressing, estrogen receptor negative. The fourth is the basal like, estrogen receptor negative and HER2-neu negative. So these subtypes are associated with different outcomes and in some instances different therapies as well. So approximately 10% of breast cancer are related to specific inherited mutations. Women who carry a breast cancer susceptibility gene are more likely to have bilateral cancer, to have other familial forms of cancer, for example, ovarian cancer, and most likely to have a positive family history, for example, any first degree relative affected before menopause. So, They might belong to some ethnic groups, for example, people of Ashkenazi Jewish descent. So, roughly one third of women with hereditary breast cancer have mutations in BRCA1 at chromosomal locus 17q21.3 or BRCA2 as well, which is located on chromosomal band 13q12-13. These genes encode large complex protein that do not exhibit close homology to each other or other proteins. So, although the molecular basis for their strong association with breast cancer risk is still being elucidated, both BRCA1 and BRCA2 are believed to function in a common DNA repair pathway. Genetically, BRCA1 and BRCA2 are classic tumor suppressor genes, in that cancer arises only when both alleles are inactivated or defective. The first genetic lesion caused by germline mutation, and the second by a subsequent somatic mutation. Genetic testing is available, but its utility is complicated by the existence of hundreds of different mutant alleles, only some of which confer cancer susceptibility. The degree of penetrance, age at cancer onset, and susceptibility to other types of cancers differ among the specific mutations. Most carriers, however, develop breast cancer by the age of 70 years, as compared with only 7% of women who do not carry a mutation. The role of these genes in non hereditary sporadic breast cancer is less clear, as mutations affecting BRCA1 and BRCA2 are infrequent in sporadic tumors. Less common genetic diseases associated with breast cancer are Liefru-Many syndrome, that is caused by germline mutation in p53, Cowden disease caused by germline mutation in p10, and we have also discussed this Cowden syndrome while we were discussing endometrial carcinoma, and also in ataxia telangiectasia gene carriers you will find some breast cancers. Then the second is hormonal influence. So endogenous estrogen axis, or more accurately, we will say hormonal imbalance, clearly has a significant role. Many of the risk factors mentioned, long duration of reproductive life, nulliparity meaning no birth of baby, and late age at birth of first child, involve increased exposure to estrogen unopposed by progesterone. So, functioning ovarian tumors that elaborate estrogen are associated with breast cancer and postmenopausal women. Estrogen stimulate the production of growth factors such as transforming growth factor alpha, platelet derived growth factors, and fibroblast growth factors and others, which may promote tumor development through paracrine and autocrine mechanisms. And the third one is environmental variables. And environmental influences are suggested by the variable incidence of breast cancer in genetically homogeneous groups and the geographic differences in prevalence, as we have discussed earlier in our podcast. Now, the most common location of tumors within the breast is the upper outer quadrant. Almost 50% of the tumors emerges from the upper outer quadrant, followed by central portion. Almost like 20% of the cancers are emerging from central portion, and about 4% of women with breast cancer have bilateral primary tumors or sequential lesions in the same breast. So, breast cancers are classified according to whether they have or have not penetrated the limiting basement membrane. And those that remain within this boundary are termed as in situ carcinomas, and those that have breached this boundary and have spread beyond it are designated as invasive or infiltrating carcinomas. So we have duct, we have lobule. So the point is that non-invasive cancers and there will be invasive or infiltrating cancers. So the duct, if it's arising from the duct and it's non-invasive, we will say that it's a ductal carcinoma in situ. And if it's arising from lobule and it is not breaching the integrity of the basement membrane, so we will say that it's a lobular carcinoma in situ. So non-invasive breast cancers are divided into two: ductal carcinoma in situ and the second is lobular carcinoma in situ. And again, when there is an invasion of this basement membrane, so we will say one, invasive ductal carcinoma, which is the most common subtype of invasive carcinoma. Then there is the second one, invasive lobular carcinoma, if it is invading from the lobular side. Then they are further divided into, like, first is invasive ductal carcinoma, the second is invasive lobular carcinoma, the third invasive or infiltrating tumor is medullary carcinoma, the fourth is colloid carcinoma, also known as mucinous carcinoma, the fifth is tubular carcinoma, and there is other types as well. So let us discuss all these tumors one by one. So first of all, non-invasive in situ carcinoma. There are two types of non-invasive breast cancer: ductal carcinoma in situ and lobular carcinoma in situ. So morphological studies have shown that both types usually arise from cells in the terminal duct lobular unit, because the lobular unit consists of duct and lobules. So ductal carcinoma in situ tends to fill and distort duct-like spaces. By contrast, lobular carcinoma in situ usually expand but does not alter the acini of lobules. Both are confined by a basement membrane and do not invade into the stroma or lymphovascular channels. So ductal carcinoma in situ has a wide variety of histological appearance. Architectural patterns often are mixed and include solid, comedo, cribriform, papillary, micropapillary, and clinging types. So necrosis may be present in any of these types, and nuclear appearance tends to be uniform in a given case and ranges from bland and monotonous, like low nuclear grade, to pleomorphic with having high nuclear grade. The comedo subtype is distinctive and is characterized by cells with high grade nuclei with extensive central necrosis. The name comedo has been derived from the toothpaste-like necrotic tissue that extrudes from transected ducts on application of gentle pressure. So calcifications frequently are associated with ductal carcinoma in situ, and that's a very important point to note. And this calcification originates as either calcified necrotic debris or calcified secretory material. The proportion of breast cancers that are diagnosed as ductal carcinoma in situ stage is only 5% in unscreened populations, but up to 40% in screened populations, largely because of the ability of mammography to detect calcifications. Ductal carcinoma in situ only rarely manifests as a palpable or radiologically detectable mass. The prognosis with ductal carcinoma in situ is excellent, with greater than 97% long-term survival after simple mastectomy procedure. In some women, distant metastases develop without local recurrence. These patients usually are found to have extensive high nuclear grade ductal carcinoma in situ, probably with small undetected areas of invasion. At least one third of women with small areas of untreated ductal carcinoma in situ of low nuclear grade will eventually develop invasive carcinoma. When invasive cancer does develop, it usually is in the same breast and quadrant as the earlier ductal carcinoma in situ. Current treatment strategies attempt to eradicate ductal carcinoma in situ by surgery and irradiations. Treatment with anti-estrogenic agents such as tamoxifen and aromatase also may decrease the risk of recurrence. Then a word about Paget's disease of the nipple is that it is caused by extension of ductal carcinoma in situ up to the lactiferous ducts and into the skin of the nipple, producing a unilateral crusting exudate over the nipple and areolar skin. And in almost all cases, an underlying carcinoma is present, and approximately 50% of the time, this carcinoma is invasive. Prognosis is based on the underlying carcinoma and is not affected by the presence of Paget's disease. Now, what about the lobular carcinoma in situ? That it has a uniform appearance. The cells are monomorphic with bland round nuclei and occur in loosely cohesive clusters within the lobules. Intracellular mucin vacuoles may sometimes form that classical signet ring type of structures are common. So lobular carcinoma in situ is virtually almost always an incidental finding because unlike ductal carcinoma in situ, it is only rarely associated with calcifications. So therefore the incidence of lobular carcinoma in situ has remained unchanged in mammographically screened populations. Approximately one-third of women with lobular carcinoma in situ will eventually develop invasive carcinoma. Unlike with ductal carcinoma in situ, subsequent invasive carcinoma may arise in either breast. So that's the important point, that unlike ductal carcinoma in situ in which the lesion was appearing in the same breast, subsequent invasive carcinoma and lobular carcinoma in situ may arise in either of the breast. And most of these cancers are invasive lobular carcinomas. However, invasive ductal carcinomas also arise from lobular carcinoma in situ. So therefore, lobular carcinoma in situ is both a marker of an increased risk of carcinoma in both breast and a direct precursors of some cancers. So current treatment involves either chemopreventions with tamoxifen along with close clinical and radiologic follow-up evaluation, or less commonly bilateral prophylactic mastectomy. So invasive and infiltrating carcinoma. So first we will discuss the invasive ductal carcinoma. So a majority of cancers fall into this group. Almost 70 to 80% of the cancers are under the umbrella of invasive ductal carcinoma. This type of cancer usually is associated with ductal carcinoma in situ and very rarely with lobular carcinoma in situ. Most ductal carcinomas produce a desmoplastic response, which replaces normal breast fat and forms a hard palpable mass. So in pathology, desmoplastic response is the growth of fibrous or connective tissue, and it is also called desmoplastic reaction to emphasize that it is secondary to an insult. So the microscopic appearance of invasive ductal carcinoma is quite heterogeneous, ranging from tumors with well-developed tubule formation and low-grade nuclei to tumors consisting of sheets of anaplastic cells. The tumor margins typically are irregular. An invasion of lymphovascular spaces may also be seen. Almost two-thirds express estrogen or progesterone receptors and about one-third expresses HER2/neu. Now, invasive lobular carcinoma, in contrast to invasive ductal carcinoma, consists of cells morphologically identical to the cells of lobular carcinoma in situ. Two-thirds of the cases are associated with adjacent lobular carcinoma in situ. The cells invade individually into stroma and are often aligned in a single file strand or chains. This growth pattern correlates with the presence of mutation that abrogate the function of ecadherin, a surface protein that contributes to the cohesion of normal breast epithelial cells. So it means that due to lack of ecadherins, it will just grow in a single file pattern. Although most manifest as palpable masses or mammographic densities, a significant subgroup may exhibit a diffusely invasive pattern without a desmoplastic response and may be clinically occult or silent. So, lobular carcinomas have a unique pattern of metastasis among breast cancers. They more frequently spread to cerebrospinal fluid, serosal surfaces, gastrointestinal tract, ovary, uterus, and bone marrow. Lobular carcinoma also are more frequently multicentric and bilateral in almost like 10 to 20% of the cases, and almost all of these carcinoma express hormone receptor, whereas HER2 overexpression is very rare in invasive lobular carcinoma. These tumors comprise fewer than 20% of all breast carcinomas. Now, inflammatory carcinomas is defined by clinical presentation of an enlarged swollen erythematous breast, usually without a palpable mass. The underlying carcinoma is generally poorly differentiated and diffusely infiltrative. Characteristically, carcinoma involves dermal lymphatic spaces. The resultant blockage of these channels leads to edema, resulting in the characteristic inflamed clinical appearance. True inflammation is minimal to absent. Many of these tumors metastasize to distant sites, and the overall 5-year survival is under 50% and understandably even lower to those with metastatic disease at diagnosis. Medullary carcinoma is another subtype of the carcinoma and accounting for less than 1% of breast cancers. These cancers consist of sheets of large anaplastic cells with well circumscribed pushing borders. Clinically, they can be mistaken for fibroadenomas, and there is invariably a pronounced lymphoplasmacytic infiltrate. So ductal carcinoma in situ usually is absent or minimal. So medullary carcinomas occur with increased frequency in women with BRCA1 mutations, although most women with medullary carcinoma are not carriers. These carcinomas uniformly lack the estrogen and progesterone receptor and even does not express HER2/neu, and it is known as a triple negative cancer. Then the colloid or mucinous carcinoma, which is also a rare subtype. The tumor cell produces abundant quantity of extracellular mucin, which dissects into the surrounding stroma. Like medullary carcinoma, they often present as a well circumscribed masses and can be mistaken for fibroadenoma. On gross evaluation, the tumor usually are soft and gelatinous, and most express hormone receptors but does not overexpress HER2/neu. Then there are the tubular carcinomas, and they are rarely present as palpable masses but account for like 10% of invasive carcinoma. Smaller than 1 centimeter with mammographic evaluation. So they usually are detected as irregular mammographic densities. On microscopic examination, the carcinomas consists of well-defined tubules with low-grade nuclei. And lymph node metastases are rare and prognosis is generally excellent. Virtually all tubular carcinomas express hormone receptors and do not show HER2/neu overexpressions. So the common features of invasive cancer is that in all forms of breast cancer, local disease progression leads to similar physical findings. Like the general physical examination will be almost same in all of these cancers, and invasive cancers tend to become adherent and fixed to pectoral muscles or deep fascia of the chest wall and the overlying skin, with consequent retraction or dimpling of the skin or nipple. And the later, like the retraction or dimpling of the skin of the nipple, is important because it may be the first indication of malignancy. And involvement of the lymphatic pathways may result in localized lymphedema. In such cases, the skin becomes thickened around exaggerated hair follicles, giving an appearance known as pau d'orange, also known as an orange peel. Now we will discuss about the clinical course of the breast cancer. So breast cancer often is discovered by the patient or her physician as a deceptively discrete, solitary, painless and movable mass. At the time of clinical detection, the carcinoma typically is 2 to 3 centimeter in size, and involvement of the regional lymph nodes, most often axillary, is already present in about 50% of patients. With mammographic screening, carcinomas frequently are detected even before they become palpable. The average invasive carcinoma found by mammographic screening is around 1 centimeter in size, and only 15% of these have produced nodal metastasis. In addition, ductal carcinoma in situ often is detected before the development of invasive carcinoma during screening. As women age, fibrous breast tissue is replaced by fat, and screening becomes more sensitive as a result of increased radiolucency of the breast and the increased incidence of malignancy. Now, the current controversy over the best time to begin mammographic screening arises from efforts to balance the benefit of early cancer detection in some women with the risk of radiation exposure and the morbidity and expense associated with clinical workup of benign breast lesions might produce a lot of false positive. Magnetic resonance imaging (MRI) is being studied as an adjunct to mammographic screening in high-risk young patients with dense breasts that are difficult to image by mammography alone. So, breast cancer occurs through lymphatic and hematogenous channels. Outer quadrant and centrally located lesions typically spread first to the axillary nodes. Those in the medial inner quadrant often travel first to lymph nodes along the internal mammary artery. More distant dissemination eventually ensues and can involve virtually any organ or tissue in the body. Favorite locations are the lungs, skeleton, liver, adrenal, and less commonly brain as well. But no side is exempted from this metastasis. So metastasis may come to clinical attentions many years after apparent therapeutic control of the primary lesion, sometimes as long as 15 years later. Nevertheless, with each passing year, without disease recurrence, the likelihood of cure increases. Prognosis of the breast cancer is influenced by the following variables, the first three of which are components of the tumor node metastasis staging classification, also known as TNM staging classifications. So, tumor invasion and size. In situ carcinomas carries an excellent prognosis, 5-year survival rate greater than 90%, as do invasive cancers less than 2 centimeter in size, 5-year survival rate of 87%. Extent of lymph node involvement. With no axillary lymph node involvement, the 5-year survival rate is close to 80%. Survival is inversely related to the number of involved lymph nodes and is less than 50% with 16 or more involved nodes. So, word about sentinel node biopsy, which is currently used for staging the axilla. So, this procedure identifies the primary lymph nodes that drain the breast parenchyma using dye or radioactive tracers, or sometimes using both dye and radioactive tracers. So, once identified, sentinel nodes are removed and examined microscopically. A sentinel lymph node that is free from carcinoma. Negative node is highly predictive of absence of metastatic carcinoma in the remaining lymph nodes. A positive node, on the other hand, is an indication for a complete axillary dissection, which is used to stage the patient's disease. So, patients who develop hematogenous spread are rarely curable, although chemotherapy may prolong survival. The 5-year survival rate is approximately 15% when distant metastasis has occurred. The most common grading system for breast cancer evaluates tubule formation, nuclear grade, and mitotic rate. Well differentiated carcinomas are associated with a significantly better prognosis than poorly differentiated carcinomas. Moderately differentiated carcinoma initially have a good prognosis, but survival at 20 years approaches that for poorly differentiated carcinomas. So, all specialized types of breast carcinoma, whether it is tubular, medullary, and mucinous, are associated with somewhat better prognosis than carcinomas of no special type, for example, ductal carcinomas. A major exception is inflammatory carcinoma, which has a poor prognosis. The presence of hormone receptors confers a slightly better prognosis. However, the practical reason for determining their presence is to predict the response to therapy. The highest rate of response, approximately 80% to anti-estrogen therapy, is seen in women whose tumor cell expresses both estrogen and progesterone receptors. So, anti-estrogen therapy may include oophorectomy or tamoxifen therapy. So, lower rates of response, 25% to 45%, are seen if only estrogen receptor is present. If both are absent, very few patients, less than 10%, respond. So, the highest rate of response to anti-estrogen therapy is seen in women whose tumor cell express both estrogen and progesterone receptors. And then when there is lower response, that can be seen if there is only estrogen receptor, and if both estrogen and progesterone receptors are absent, so very few patients respond to therapy. Overexpression of HER2/neu membrane-bound protein is almost always caused by gene amplification and can be determined by immunohistochemistry, which will assess its protein level, or by FISH technique, which is known as fluorescence in situ hybridization, which assesses the gene copy number. Overexpression is associated with poor prognosis. However, the clinical importance of evaluating HER2/neu lies in predicting response to trastuzumab, which is also known as Herceptin, which is a monoclonal antibodies body that binds and inhibits the function of HER2/neu. And this remains one of the best characterized examples of an effective therapy directed against a tumor-specific molecular lesion. So the question arises that why some cancers recur after post-operative therapy while others do not. It still remains a mystery. So, as mentioned earlier, that gene expression profiling of breast cancers on microarray or gene chips has defined several molecular classes of breast cancer and also has been used to develop commercial tests that may predict the response of an individual patient's tumor to chemotherapy. And at present, there is insufficient data on the prognostic values of such tests. So, let us summarize the details which we have discussed in our today's podcast. Is the lifetime risk of developing breast cancer for an American woman is 1 in 8. Almost 75% of breast cancer diagnosed at the age of 50 or after the age of 50. And risk of developing breast cancer is related to estrogen exposure, Genetic factors, long duration between menarche and menopause, atypical proliferative lesions, and family history of breast cancer in a first degree relative like a mom, daughter, particularly if the disease was multifocal or on premenopausal women. So, almost 10% of all breast cancers are caused by inherited mutations. BRCA1 and BRCA2 genes account for one third of the cases associated with single gene mutations. Ductal carcinoma in situ is a precursor to invasive ductal carcinoma and is typically found on mammographic examination as calcifications. And when carcinoma develops in a woman with previous diagnosis of ductal carcinoma in situ, it usually is invasive ductal carcinoma in the same breast. And in contrast, the lobular carcinoma in situ frequently is an incidental finding and usually is not associated with calcification. When carcinoma develops in a woman with previous diagnosis of lobular carcinoma in situ, it may occur in the affected or unaffected breast and usually is invasive lobular carcinoma but may be invasive ductal carcinoma as well. The natural history of breast carcinoma is long, with metastasis sometimes appearing decades after the initial diagnosis. Prognosis is most dependent on tumor size, lymph node involvement, distant metastasis at presentation, tumor grade, and histologic type. Estrogen and progesterone receptor status and expression of HER2/neu are used primarily to determine response to treatment. Estrogen receptor expressing tumors are more likely to respond to tamoxifen. HER2/neu overexpressing tumors often are treated with trastuzumab. And this concludes our podcast for today. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.